Good afternoon, everyone. This is our fourth and final session of the Learning Collaborative on integrating care for older adults and specifically integrating primary care, oral health, and behavioral health for older adults. And in this fourth session, we will explore integrating training and care delivery with a focus on behavioral health. You may recall a few weeks ago that we had the National Network for Oral Health Access, or NOHA, come and discuss integrated and training and care delivery with a focus on oral health. So in this session, session 4, we have several objectives to understand the impact of siloed care on older adults, to learn about models of integrated private provider training with specific focus on primary care and behavioral health integration for older adults with chronic comorbid conditions, to learn about models of integrated care delivery with specific focus on primary care and behavioral health integration for older adults with chronic comorbid conditions, including exploration of the patient-centered medical home, or PCMH model, and to share ideas and best practices of integrated training and care delivery for meeting the needs of older adults with chronic comorbid conditions. And ultimately to hopefully get out of this a conceptualization and drafting of a readiness assessment toolkit. So let's move on to understanding the impact of siloed care. And as something that we've discussed previously, oftentimes disciplines are siloed and have been in the past, and we are seeing more and more work done with respect to the integration of behavioral health in primary care and the integration of oral health in primary care. Separate physical and behavioral systems can often lead to fragmented care delivery in that providers have not communicated with each other, not only in terms of communicating referrals in a proactive way, but also understanding what each respective discipline was doing with regard to that patient. And a fragmented delivery of care can lead to poor health outcomes. Patients there might be missed opportunities where something is not picked up in a timely manner, and may lead to a health outcome that is poorer than it could have been if it had been picked up earlier. This, of course, can lead to higher costs of healthcare delivery, and also can potentially lead to duplication of services. Behavioral health integration can increase access to behavioral health services for rural residents and reduce the stigma associated with seeking the services, as well as maximizing the resources available. So thinking about our population of interest, older adults and behavioral health issues, among individuals 65 years and older, 1 in 6 can suffer from depression. And in older adults, it's estimated that depression occurs in 25% of those with other illness, including other chronic debilitating illnesses such as cancer, arthritis, stroke, chronic lung disease, and cardiovascular disease. Additionally, in the older adult population, other stressful events such as losing friends and loved ones can also be a risk factor for depression. And opportunities can be missed to improve health outcomes when mental illness is both under-recognized and under-treated in primary care settings. We've also seen that older adults can have a higher risk of suicide compared to other age groups, and that these patients are important in the primary care setting because approximately 50 to 75% of older adults who commit suicide saw their medical doctor the month prior for general medical care, and approximately 40% were seen during the week prior to their death. Symptoms of major depression that might be felt on a somewhat daily basis can include, but may not be limited to, feeling sad or having an empty feeling, a loss of interest in daily activities, either weight loss or weight gain, even when the person is not dieting or seeming to change their eating habits, not being able to think clearly or concentrate, becoming tearful at different moments that in other times may not lead to tearfulness, and feelings of unworthiness or worthlessness, and then lastly, if they have suicidal ideation or thoughts of death. So in addressing behavioral health along with physical health, oftentimes untreated or undertreated mental illnesses can have serious consequences. We know that people with severe mental illness may actually die decades earlier than the general population from medical conditions that could be treated by a primary care doctor. And we also know that adults with serious mental illnesses and substance use disorders can have higher rates of chronic physical illnesses, which also may lead to earlier mortality. And that conversely, we know that people who might have common physical health conditions can have a higher rate of mental health issues as well. And in primary care settings, medical providers can provide almost half of all mental health care for, or I should say, do provide mental health care for common psychiatric disorders. In a section of the Social Security Act permits the Centers for Medicare and Medicaid Services, CMS, to add coverage of additional preventive services through the National Coverage Determination, or NCD, process if the following criteria, all of the following criteria are met. If it's reasonable and necessary for the prevention or early detection of illness or disability, and if it's recommended with a grade of A or B by the United States Preventive Services Task Force, and if it's appropriate for individuals entitled to benefits under A or enrolled under Part B. Screening for depression in adults is recommended with a grade of B by the USPSTF. And so CMS had reviewed the recommendations by the Preventive Services Task Force and the supporting evidence for screening depression in adults preventive services, and did determine that with the criteria listed, enabling CMS to cover these preventive services, so that screening for depression was considered to be reasonable and necessary for prevention of depression or early detection of depression, and that it was appropriate for individuals entitled to this benefit. So in 2011, Medicare began to cover annual screening for adults for depression in primary care settings. And as the slide shows on the CMS website, that has staff-assisted depression care supports in place to assure accurate diagnosis, effective treatment, and especially follow-up when a screening is positive. And so when we talk about integrated care combining primary health care and mental health care can potentially happen in one setting. And there's many ways to integrate care, and they could go by different names, such as collaborative care or health homes, excuse me. And providing integrated care can help patients and their providers. It blends the expertise of mental health, substance use, and primary care clinicians with caregivers and patients' feedback. And this creates a team-based approach where mental health care and general medical care are often offered in the same setting. And coordinating primary care and mental health care in this way can help address the physical health problems that people with serious mental illnesses may have. Addressing the whole person and their physical and behavioral health together is important for promoting positive health outcomes, as well as potentially creating cost-effective care. Many people may not have access to mental health care or a mental health provider, or they might prefer actually going to their primary care to receive all their care. And so, although most primary care providers can treat mental disorders, that might not be enough for some patients, and it has been difficult for primary care providers to offer effective, high-quality mental health care when working alone. So combining mental health services and expertise with primary care can increase the quality of care, but as well as reduce costs and hopefully save lives. So when we talk about integrated care for behavioral health, we can think about it in terms of different types of models. The Substance Abuse and Mental Health Services Administration, SAM-HSA, and the Health Resources and Services Administration, HRSA, have developed a standard framework for levels of integrated care. And the framework actually describes three main categories of care between behavioral health and primary care practitioners. The first level is coordinated care, and this type of care includes minimal collaboration or basic collaboration at a distance. And here, primary care providers and behavioral health providers communicate about shared patients, but would maintain separate facilities and systems. And so in this framework with coordinated care, the focus is on communication between the providers. In the second category of care, co-located care, this type of care includes basic collaboration on site or close collaboration with some systems integration. And so behavioral health and primary care providers in a co-located practice may share the same facility, but not necessarily the same practice space. So co-located care could be considered or has a physical proximity focus. And then the third category of care is integrated care. And in integrated care, it involves a close collaboration in a partly integrated practice or full collaboration in a transformed or merged practice. And so providers in this type of care category jointly plan and execute goals, develop integrated care plans, co-manage patients, and maintain shared schedules. So in an integrated practice, they would use a systematic clinical approach to identify patients who are in need of behavioral health services, and a shared decision-making would engage both types of providers as well as the patients. Another framework to understand, or I should say another framework to understand, another way to look at these three different categories of care is in this framework or chart by SAMHSA that describes not only the three categories of care, but 6 levels of collaboration and integration with core descriptions. So thinking about what within each category, what are the different levels of collaboration or integration, and what descriptions would fall under each level. So, for example, in coordinated care, where the key element or the focus is on communication, we can have as level 1 a minimal amount of collaboration. And so when we can think about where they work, and so they would work in separate facilities and they would have separate systems. They would communicate about cases only rarely and under compelling circumstances. Their communication would be driven by provider need. They may not actually ever meet in person in terms of their coordinated care, and they would have a limited understanding of each other's roles. In level 2, we would see basic collaboration at a distance. Again, being in a separate facility, they would have separate systems. They might communicate periodically about shared patients. And here, communication might be driven by specific patient issues. And they may meet, but they might meet as a part of a larger community. and they would have some appreciation for each other's roles as resources. If we look at the other end of the spectrum in terms of the integrated care category, where the key element is practice change, in level 6, where we have full collaboration in a transformed, merged, integrated practice, the physical proximity, they'd be in the same space, within the same facility, sharing all practice space, and they would have resolved most or all system issues functioning as one integrated system. They would communicate consistently at the system team as well as the individual levels, and they would collaborate where the driver would be a shared concept of team care. And they would also have formal and informal meetings to support the integrated model of care. And so this framework, as I mentioned, describes the 6 levels of collaboration and integration with descriptions that people can use to think about how to frame their behavioral health integration into their practice. In the slide previously, I talked about the key differentiators, or the 6 different levels of practice and the core descriptions. We can also think of this framework with the 6 levels having key differentiators in both clinical delivery as well as patient delivery, so that in the key differentiator in clinical delivery from level 1 to level 6, in level 1 with minimal collaboration, you would have screening and assessment done according to separate practice models. There would be separate treatment plans, and the evidence-based practices would be implemented separately. In an integrated care plan, again with a level 6 full collaboration in a transformed or merged integrated practice, population-based medical and behavioral health screening would be the standard practice, with results available to all and response protocols in place. There would only be one treatment plan for all patients, and the evidence-based practices are team-selected, trained, and implemented across disciplines as a standard practice. In looking at the key differentiators with patient experiences, again comparing the coordinated care category and the minimal collaboration, or level 1, the patient's physical and behavioral health needs are treated as separate issues, and the patient is the one who negotiates the separate practices and sites on their own, oftentimes with varying degrees of success. In the integrated care category, with full collaboration in a transformed or merged integrated practice, the highest level, level 6, all patient health needs are treated by all patients by a team who function together in an effective manner, and patients can experience a seamless response to all their healthcare needs as they present to a unified practice. So in this next slide, again, looking at the framework between the 3 different care categories and the 6 different levels, we can see both the advantages and the weaknesses within each of these 6 levels. So for example, under coordinated care, in level 1, an advantage is that each practice can make timely and autonomous decisions about the care, and readily understood as a practice model by patients and providers. This is a practice model that they are familiar with. A weakness is that services might overlap. They might be duplicated and potentially even work against each other. For example, if a primary care provider is trying to manage depression in a patient, but the patient also sees a mental health provider or counselor as well. And additionally, important aspects of care may not be addressed, or they may take a long time to be diagnosed. In the integrated care category, in the full collaboration in transformed or merged integrated practice level, an advantage is the opportunity to treat the whole person, that an individual's whole health is considered, and not just the health area that particular provider is known for. All or almost all system barriers are resolved, allowing providers to practice as high-functioning teams, and that all patients' needs are addressed as they occur, so that their needs are met in a timely manner, and nothing falls between the cracks. And then lastly, shared knowledge base of providers increases and allows each professional to respond more broadly and adequately to any issue. The weakness of the fully integrated collaborative approach is that sustainability issues may become very stressful for the practice in terms of being able to manage a fully integrated practice and ensuring that all of the system barriers are resolved. And that there are few models at this level with enough experience to support the value, and that outcome expectations may not yet have been established. So as more integrated practices are coming on board, it will be important to see how they are functioning, how they are becoming sustainable, and what their experience has found with respect to either value-based care or patient outcomes. So another integrated care model is something that I think we've covered previously, and that is the patient-centered medical home. Patient-centered medical home involves coordinating a patient's overall healthcare needs, and patients play an active role in their healthcare. Providers coordinate all aspects of preventive, acute, and chronic needs of patients using the best available evidence and appropriate technology. And so, as a result of the Affordable Care Act, health homes were established for individuals on Medicaid, in particular with chronic conditions, including mental health and substance use disorders, asthma, diabetes, heart disease, and obesity. And health homes are team-based with a whole person approach with specific emphasis on integration of behavioral health and primary care, and that they provide comprehensive care management as well as coordination and follow-up, and they can offer both patient as well as family support including referrals to the community and other outside support services. So integrating behavioral health into PCMH. In the PCMH recognition, this is from 2014, we look at disclosing the scope of behavioral health services to patients and establishing referral agreements with behavioral health providers. Integration of physical and behavioral health services can help older adults living in rural areas to help them access needed healthcare services as well as other areas. And one particular program, the Program for All-Inclusive Care for the Elderly, or PACE, is a model that is designed to integrate care for frail older adults who are dual eligible, both eligible for Medicaid and Medicare. And this population of dual eligible individuals is often more likely to have physical, mental, and cognitive conditions and can highly benefit from an integrated care model. Some PACE programs are targeted toward all older adults who meet the minimal acuity levels required for nursing care. PACE services are provided by interdisciplinary teams, which are responsible for coordination of 24-hour care delivery. PACE provides all Medicare and Medicaid benefits, and these include adult daycare, meals, social services, transportation, primary care, nursing home care, and home care. And this integrated model of care aims to improve the quality of life of older adults with chronic care needs by providing services in the community when possible. And so, for example, in rural settings, PACE programs are located either in a larger healthcare system or in a local agency or organization. And there's the National PACE Association has a toolkit for states with strategies for incorporating PACE into state integrated care initiatives, as well as information for communities to develop their own PACE program. Some examples of rural PACE programs, there's a PACE program, Senior Unity Care, where U in community is capitalized. And this is a program that serves older adults in two rural counties in Colorado. And this program addresses all medical and social needs of enrolled patients, including transportation services, meals, nursing, dental, and mental health care, as well as other services. Another PACE program, Northland PACE, which serves older adults in a couple of communities in North Dakota, coordinates healthcare and home care services for enrolled patients through care teams. And their care teams include a range of providers, including physicians, nurses, social workers, licensed therapy professionals, as well as home care attendants. So when we think about our health centers ready to integrate, there's actually work done with the National Association of Community Health Centers, or NAC, and a learning community in which 11 health centers participated. This was the Behavioral Health Integration Learning Community. And the learning community met with coaches, and it operated in a relatively short time frame. This was in mid-2012 to early 2013, and that the learning community wanted to come together into initiative with a potential commitment for change. And so the program, or the community, Ready, Set, Integrate, and in an interview that was done with the facilitators of this learning community, had talked about some of the things that had come out in the learning community session. And so one thing to note was that they said readiness was key, that it shouldn't be work to undertake unless the people are ready to do it. And so asking the question, is the health center ready to integrate? And the first sub-question is the organization. Is the organizational culture ready? Are the senior leaders on board? Is it a priority? And then second, is the organizational infrastructure in place? Is there staffing or a measurement system in place? And so they gave the example that if an organization is in the process of restructuring, it might not be the time to integrate services. The second question, what does the health center want to achieve? And so they should think about creating a set of measures, both starting from process measures all the way through to client satisfaction members, and to think about measurement, but also to put into place the infrastructure to collect this information, and then also thinking about how this information that's been collected, how it will be analyzed, and then how the information will be shared back in terms of what is actually happening. The third question is, what is the value to the health center of integrating? So illustrating the value is very important. And in order to do this, they suggest using real-world client stories to emphasize. And so also thinking about in terms of what is the value, what can they do with the resources that they have? Are there return on investments that can be realized quickly, as well as efficiently if the resources are below? So when we think about integration. This is from an article by Ratzlaff et al. Practical Approaches for Achieving Integrated Behavioral Health Care in Primary Care Settings, and they talk about these in terms of practical approaches. They address 4 different questions that they've come up with the acronym GROW, and utilize a worksheet that I'll show you. That actually I won't show you. So the questions are, which population of patients are you targeting? So thinking about your goal, who is it that you are targeting? So in our population of interest, you'd be targeting older adults. Are they older adults who may have multiple chronic conditions, including behavioral health issues. The second area, resources. What are the resources available to us? What challenges with resources need to be addressed? Are there infrastructure issues that need to be addressed? And then third, options. What capacities do we have now, and how can we create capacity to integrate behavioral health? Are there things, are there capacities that currently exist within the system? Is there something within an EHR that allows for better referrals and follow-up from referrals? And then lastly, thinking about the workflow. What changes will need to be in place for us to deliver integrated behavioral health? So is there screening being done at the primary care site? If so, what happens? What is the protocol if somebody is screened positively for a behavioral health issue like depression? What is the referral protocol? How is that followed up? Do there need to be changes in the EHR or the record keeping in order to ensure that a more integrated behavioral health is in place within the primary care site? So, thinking about these 4 different areas with respect to integrating behavioral health in a primary care setting. So I wanted to leave with the overall question of what are the elements that are necessary to understand readiness for integration of primary care and oral and behavioral health services for older adults among health centers. Is understanding readiness for integration, is it the same for all health center populations, or are there specific things that need to be thought about for older adults in terms of achieving integration? Are there things that the older adult population brings to the health center that either make the case for integration, as well as are there aspects of older adult care that that may preclude a health center's readiness to integrate? And so thinking about what those those elements are, and trying to determine a readiness assessment structure that would be helpful for health centers as they are thinking about integrating primary care and oral health, as well as primary care and behavioral health, and thinking about their older adult population specifically. So this last piece is a worksheet. This is from the, again, from SAMHSA. This is Behavioral Health Integration from the AIMS Center. And this is a patient-centered integrated behavioral health care principles and tasks. And this is a checklist tool that was developed to in integrated behavioral health care, and it was done in conjunction with and the support of several different groups. And so the core principles of effective integrated behavioral health care include a patient-centered care team providing evidence-based treatments for a defined population of patients using a measurement-based threat-to-target approach. And so in the checklist, the health center can look at whether or not they apply this principle in their patients. And so they have aspects of principles of care, as well as core components and tasks. So they say that core components and tasks are shared by effective integrated behavioral health programs, and that with the AIMS Center Integrated Care Team Building tool, they can help organizations build clinical workflows that incorporate these core components and tasks into their settings. And again, with the core components and tasks, they have 7 components under as part of their checklist. So something that you can use as a resource in terms of thinking about integrated behavioral health care and what the principles of care are, as well as what the core components and tasks. And so lastly, if you are interested, this roundtable was hosted by CIHS. This occurred July 12th, and you might be able to find the discussion on this, but this is the Medicaid Medicare reimbursement for behavioral health integration services roundtable discussion for health centers. And so if you are interested in that, you can look at CIHS's website to find out more information, if they have a recording from the roundtable discussion, or have subsequently posted materials from that discussion. So thank you very much. As I said, this was the 4th session in the Learning Collaborative for integrating primary care, oral health, and behavioral health for older adults, and thinking about the readiness of health centers to integrate oral health and behavioral health into their primary care into primary care with a specific focus on older adults. Thank you very much and have a good afternoon.